So how much of the research that you've seen in cancer will apply more globally to cancer, like breast cancer and prostate cancer, and then the metastatic?
Well, much of it will, even though companies are targeting their current pharmacologic drugs towards prostate cancer or other cancers, we find that they have beneficial effects, and then we spread them over to look and investigate them in other tumors. So we're now investigating a lot of drugs which have been shown to be beneficial in lung cancer and breast cancer, in prostate cancer. And these are the PARP inhibitors. And so as we understand more about the genes that all of us have in our system that we inherit, plus the genes that are present in our tumors, the more we can understand when some of these new drugs that have been found to be useful in other cancers, like ovarian cancer and breast cancer and lung cancer, the more that we see that these might be able to be targeted to patients who have prostate cancer. So you're absolutely right to raise the question, Brian, about how much of this spreads over into other cancers. And that's been very, very common. One of the other things that's been very common nowadays is that as we realize that all prostate cancer is not one cancer, that there are lots of different subsets of prostate cancer, understanding the genes that are in the cancer, the genes that are in the bodies of all of us who may have prostate cancer, the more that we understand these, the more we can then logically work with the patients and choose the therapies that may be effective for them. And these therapies then can result in some very marked increases in the time, the duration of control of the disease, and the time until we need some new treatment of the disease. And many times also increased overall survival, which is always that's always the gold stone of, is this going to be an effective treatment? But as we all know who are on the call today, prostate cancer is a very long-term process. And overall survival is dependent upon lots of things besides the prostate cancer. So making certain that these advances don't have a lot of side effects that may cause other problems. So one of the most common things is androgen deprivation therapy, ADT, Lupron, other drugs. And we know that these types of therapies can have side effects with some weight gain, and side effects with a slight increase in risk of cardiovascular complications. So you want to make certain that if you're doing therapies, that you understand what the side effects may be, and work with your internist, your primary care physician, and the oncologist, urologist, to make certain that you're reducing any of those risks, make certain you're getting all the benefits without getting some of the problems that may go along with it. And one of the things that my patients complain of most commonly to me is, oh my goodness, I've been gaining weight on this, and oh my goodness, now I've got to start taking some statins to decrease my cholesterol because I got to protect my heart and watch my blood pressure a little more closely. And my wife is beating me over the head, telling me I can't eat this and I can't eat that. So we all know that this is a process where we have not only the doctor and the patient, but we've got the whole family involved, and then you got the support groups with everybody sharing information, everything. So it is a whole process, and one that's exciting to see how advances are being made. So it's good.
Good evening, everybody. Welcome to Prostate Forum of Orange County. We're delighted to have as our fireside chat speaker tonight, Dr. Cary Presant. Forgive me if I don't pronounce your name right, and straighten me out if I don't pronounce it right. We are once again talking about the white mushroom study and getting updates from the doctor's research at the City of Hope. We kind of got going before all you guys got here, and the doctor is going to get us caught up. And I thank you very much, Doctor, for joining us. And I'm going to mute myself and give the floor to you.
Well, thanks very much. Appreciate the introduction. I'm Cary Presant. I'm a professor over at City of Hope. My office is located in West Covina, and my research office is over in Duarte. And on this project, we have physicians who are in Orange County, both in Newport and in Irvine at the new Lennar Center, the hospital there, that's open, that has opened and is continuing to open with more and more different facilities that are available. So we have urology down at Lennar with Jeff Yoshida, Dr. Yoshida, and with the medical oncologist, we'd have Dr. Richard Lee, who's over at Newport. So we have, access for people who want to consider participating in this study of white button mushrooms. Now, white button mushrooms represent about 85% of all the mushrooms that are sold in America. And you all know them because when you go to the store, the baby bellas, the white button mushrooms, they're all on the shelf. And you can buy those and put them on your salads and do other things like that. But the reason this became very interesting is because a few decades ago, when I was working with white button mushrooms at Washington University in St. Louis, we found that the mushroom extracts could bind to cancer cells and could reduce their rate of growth. And furthermore, they also could bind to lymphocytes, our body's immune cells, and they would turn on the immune system. And so that was an observation that we made, and it bubbled along. And in the last 10 years, we've seen that there's been a lot better molecular understanding of what's going on with the white button mushrooms. And so when you look at the white button mushroom extracts, they can increase the immunity in mice. They can improve the microbiomes, that is the stool germ sets that people have. They can improve those, and they can reduce the growth of prostate cancers in mice. So about 10 years ago, this was transferred over to some clinical studies at City of Hope, and they've been published. And it was quite remarkable that, number one, many of the patients had a decrease in their PSA. These are patients who had prostate cancer. Many of them had remissions in their metastatic prostate cancer, where they had lumps or masses, both in the lymph nodes or in the prostate, or they have masses in the bones, and these actually reduced in size. And so that was a finding that was very interesting, but not conclusive, because everybody got the mushrooms. And so now we have a large study at City of Hope, including Orange County and Duarte, and in our network of community offices, as well as in conjunction with Dr. Twardowski, who was at City of Hope and moved over to St. John, Santa Monica, and he's putting patients there on study also. And with this new study, the National Cancer Institute gave us a large grant to study whether or not extracts from white button mushrooms could actually control early prostate cancer. And so we're now putting patients with early prostate cancer onto mushroom pills, or just watching them without the mushroom pills, and we'll add the mushroom pills later on if we find that it is a positive study and that it can help them to control their disease. So we take mushrooms and we lyophilize them in a commercial lyophilization company. We then take this lyophilized extract and we test it at City of Hope to make certain what its concentration is of the molecules that will enzymatically control prostate cancer. And then we formulated these up into just capsules, and these capsules are given to men who are on the mushroom arm, and other men who are not on the mushroom arm are followed a little bit more carefully than they might be otherwise to see how they're doing. And what we measure with this is, first of all, of course, what is the PSA doing? We also measure how is their immunity being affected. Are they having an increase in their immunity, or is the immunity just bubbling along and not getting any better or even getting worse? We also test to see if there are changes in prostate cancer, other prostate cancer markers. And if the patient has another biopsy, we actually look to see if there are changes in the immune cells that are infiltrating into a patient's prostate biopsy. And so we correlate this all. We test it with statistical analyses. Some of it may include AI as we go forward, because there are so many different things that we're measuring. And that will tell us for sure if the white button mushroom pills actually can control early prostate cancer. Now, what do we mean about early prostate cancer? The guys who are eligible for this study are patients who've had biopsy-proven prostate cancer, but they have low-grade prostate cancer. That means Gleason's 3+4 or less than that. So 3+3, 3+4 are the majority that go on. And that these are patients who are not on any kind of therapy now. So they're in the group of watchful waiting. So that's one group. The other group is a group that's already been treated for prostate cancer. And then they've had their surgery, they've had their radiation therapy, they may even have had some hormonal therapy or even docetaxel at the time that they were getting treated for their prostate cancer, their localized prostate cancer. But they're in remission, and we find that as we follow them that if their PSA is going up, so they have what's called a PSA recurrence, but no evidence of any metastatic disease or any disease that's come back in the prostate or in the lymph nodes, then these patients are also eligible. And they, again, are getting, 2/3 of them are getting the pills, and 1/3 of them are just getting watched. And of course, whenever the PSA goes up further, those patients are then treated. And if one is in a patient's in the control arm and their PSA comes up, they can then switch over and get the mushrooms to further control that disease. So a lot of patients are eligible for this. We've now accumulated about 2/3 of the numbers of patients that we need to go into the study. So we're anticipating we're going to have results that come out in about roughly a year to a year and a half. And so we'll be able to report back to everybody here what's going on with this. But at the present time, if any of you who are online or any of your buddies who have prostate cancer would like to learn more about this and see if they might be eligible, then by all means, contact either myself, contact Dr. Richard Lee down at Newport, contact Dr. Jeff Yoshida down in Irvine at Lennar. He's the urologist down there. Contact Dr. Twardowski, who's the medical oncologist over at St. John's, or Dr. Clayton Lau, who's our urologist over at Duarte. And any of us can provide more information to you. I'm very available to patients so we can see if they'd like to participate in the study. So the question is, why would you want to participate in the study and not just take some mushrooms? Well, first of all, you have to take an awful lot of mushrooms off the shelf at the supermarket in order to get enough mushrooms to have the effects that we've seen in our early stage studies. Secondly, we know that our preparation of the white button mushroom extracts is a special preparation. It's prepared in a special fashion, and it is assayed to make certain that it's got all the active ingredients in it. Whereas if you buy mushroom powders off of the internet, things like that, that may not be the best source, because we don't know if those are going to be the kinds that have active components in them, or if they do not have active components in them. The pills are free. The visits with the doctors are all covered by insurance and everything. So that is good. And most of all, if one participates in the study, you have access to the follow-up information right away as to what's going on. Whereas they are giving out this information to the general public will be delayed at least 6 months to 12 months after we complete the study, whereas patients who are participating in the study will get that information right away if they are going to potentially be benefited by the mushroom pills. So we're doing that. Now, the other thing that's very interesting, I mentioned that these mushroom pills increase immunity. One of the things that all of us are doing nowadays, or at least most of us, we're getting COVID vaccinations. Plus, we're getting flu vaccinations and all other kinds of vaccinations. But we realize that this is an opportunity for us to look at the men who are participating in this trial and say to them, listen, if you're going to have another COVID booster, we'll draw 3 samples of blood and determine how well you responded to your COVID vaccination. So we'll actually measure the antibodies against COVID and see if the mushroom pills have helped to increase the amount of immunity that you've gotten, and if that immunity is lasting longer compared to men who have not had the mushroom pills. This may help people throughout America who get vaccinations of any kind in the future if we find that these, as we think they will increase the body's response to a vaccination. And there's no problems with getting mushroom pills together with the vaccine. The other thing that we found in mice was the white button mushrooms improved the microbiome, that is the array of germs in the stool of a mouse. And so now we know that men are being followed on this, and some of them are getting mushrooms and some of them aren't. We can take a very small stool sample and over the course of a couple of samples, know whether or not the mushrooms have improved their microbiome and also improved their immunity at the same time. This may help in determining how we can improve the microbiome, one of our body's major defenses against infection and cancer, how we can improve the microbiome of people throughout America. So people who participate in this study, the men who are in the study, know that this information is going to be able to help not only them, but also help their families and help other men throughout the country. And in fact, help other patients throughout the country with other diseases as we go forward. And so we're already starting a white button mushroom study in breast cancer. So that's already ongoing. And we'll be able to understand a lot more as we go forward in a little while. So we're interested in giving you more information as time goes on. We're interested in responding to any of you who'd like to participate in this trial. It's going along very well. Almost no one has dropped out of this study for any reason. No toxicity, no kinds of problems that we're seeing with patients. And the only side effect that sometimes people get is they take a lot of pills, so they get a little bloating sometimes with it. So it's kind of things that we can help patients to get by that. That's a very easy solution. So the patients don't drop out of the study. Out of about roughly now we have about 90 patients on study. We've had 2 men who have dropped out of the study because of they didn't want to continue on. And we don't know if that's because they didn't want to take pills or other reasons, but it hasn't been due to toxicity. So that's good. So that's where we are at the present time. I'm happy to answer any of your questions about any of the things that are going on in prostate cancer, and specifically about the mushroom study that we had, to see if any of you might like to get more information. And in the chat, we put on the contact information for all of us who are involved in the study. So you have Dr. Richard Lee down in Newport. You've got Dr. Jeff Yoshida, who's in Irvine, Dr. Twardowski, who's over in Santa Monica, Dr. Clayton Lau up in Duarte, and myself in West Covina. And we're happy to chat with you at any time and see what we can do to help you out. So the floor is open for questions. Anyone have any questions for me?
I got one question.
Yep.
I'm taking a GnRH antagonist for my prostate cancer. Is there any contraindications with the Orgovix taken with the mushroom medication?
Well, we don't want patients who are on other active treatments at the present time. And so I think it's something that, we'd have to look at your medication list and see if that's going to get in the way of participating in the trial and everything. So we'll see what's happening. Let me see if, can you hear me okay?
Yeah, I can hear you. I just lost
Okay,
my
good.
visual.
Because my computer just decided to have some fun here.
Oh,
So
okay.
let's see.
I thought that was me.
Okay, well, so that's something, I'm happy to share that information with you, later, if you'd like to offline, to see what medications you've been on in the past and what your status of your disease is, and see if we can get you on the study. Okay?
Yeah, thanks.
So just give a call over to the office or shoot me an email, and we'll be happy to talk with you. Okay?
Thank you.
Good.
Can someone who is not local participate in your study?
There are, we got a question in the chat of someone on the East Coast participating in this. I guess that's you. No.
Maybe,
I hope your weather's okay out there. We hear that
Uh,
heat is coming your way.
Yep,
The answer is that we don't see a way that that can be done easily right now. It is easy if you find your way over to Southern California to be seen by one of us. But I think that we've not, because you need an examination according to the restrictions on the study. So we can't examine you long distance. We can do telehealth with you. And so that works out okay, but we can't get you onto the study if you're back east. On the other hand, if you find that you're going to be in Southern California, let us know, and I'll be happy to evaluate you, see if we can get you on the study with this. But we have to get bloods drawn that enable you to be on the study, either at one of our participating facilities, and have to have an examination with that. So I regret not yet. On the other hand, by participating in this prostate cancer support group, as we get information, that information, you can take that information back to your urologist and see if there's some way that you can make use of this once we have some conclusions from the study. So I'd urge you to continue to be online with the support group and listen to the updates as we give them. And I think updates every 4 to 6 months would be quite reasonable for us to participate together.
okay. A follow up on that. I have family in San Diego and I might come out to visit next year.
Sure.
If I initially were physically present for
Yes.
the exam and blood draw, et cetera, at that point, could I then be, remote going forward?
Possibility of that exists to see what's happening, because we've done telehealth visits with a lot of the patients. So that's something that as you find out when you're coming, let me review that with the statistician, the principal investigator, to make certain, where we would get bloods drawn and how we would get them shipped over to one of our participating units, so we can know that everything's okay.
Okay, this won't be for a year anyway, but I'll keep that in mind.
On the other hand, I think, you could stay in Southern California for a while and have fun out here.
Yeah, I could, yeah.
Yes.
I have a
Other questions that people have?
I have one.
Yes, Chuck.
Yes, a couple of them, maybe 3 of them.
Sure.
Number one, does this mechanism of or possible mechanism of the mushrooms work on the DHT?
The testosterone levels that we see in our patients have tended to go down slightly, but not as much as with ADTs. But we think that that is not the major mechanism by which this is helping, because what we found is that in experimental animals who have testosterone independent cancers, that the mushroom extracts work well in them. And the reason it works well in them is, number one, the increase in the immune response. And number two, it actually decreases a lot of the genes the growth genes that are present in cancer cells. So this is not going to be specific just to patients with prostate cancer. We think that these results, if they're as positive as we think they're going to be, will be translatable into other cancers as well, because almost every cancer is dependent for these growth genes to be active and to be promoting the growth of the cancers. And nearly every cancer is able to be controlled by one or another of the immune active drugs. And you've heard about these drugs, Opdivo, Keytruda. These are drugs that are commonly used around the country now for lots of different cancers, including lung cancer, breast cancer, and gastrointestinal cancer. And so we see a lot of this being used, and I think that that is something that is part of the mechanism of action of how we see white button mushrooms having their effect. So yes, there's a little decrease in testosterone. We'll be measuring that in the blood samples in patients who get mushrooms, if patients don't get mushrooms, to see how things are going with that. But we'll see a little effect, but I don't think we're going to see a big effect.
I have two more questions.
Sure.
One is, I remember seeing, I was looking for it now before the meeting, a report from some journal or something about the antibiotic ciprofloxacin.
Yes.
You know, and you may have seen it. I think this thing was around 2010 or something, where some observer or scientist. One thing personally is that over the maybe a few years, I won't get into all the details, but I would think that I would have some type of a prostate infection. Okay,
Mhm.
and of course it would
Right.
inhibit urination to almost effect of saying, wait, I got to get something. So I'd have an antibiotic given, ciprofloxacin,
Mhm.
and probably just looking at the pill, one or two pills, it would relieve me for whatever that symptom was of urination. And I would have, in not all cases, sometimes would have the urine tested through my urologist and say, gee, we can't see anything in here. You know, there's no
Mhm.
thing. Have you seen anything with this? I know you don't, everybody shouldn't take ciprofloxacin because of course it's antibiotic and stuff, but have you heard anything of this nature?
Yeah, there's been a lot of interest in the antibiotic therapy and the way that interfaces with cancer treatments. Cipro or ciprofloxacin and levofloxacin, another very commonly used drug in treatment of acute prostatitis or chronic relapsing prostatitis, the kind of infection that you may have, and even treatment of urinary tract infections, because a lot of guys have urinary tract infections that may go along with their disease in their urinary tracts. And so these types of antibiotics are very, very commonly used. And what we found is that when these antibiotics are used, they change the microbiome in the stool. So instead of having a nice range of germs in the stool that increase the body's immune response, they tend to have only a very limited number of germs in the stool and the kind that do not increase the body's immune response. And what's been found is that if you look at the immunotherapy of cancer with Keytruda and Opdivo and all, there's now about 6 or 7 different of these immune checkpoint inhibitors that are used to increase the body's immune response and control cancer. If patients have had Cipro or other types of antibiotics, particularly broad spectrum antibiotics like Cipro, that their response to immunotherapy is markedly reduced. And therefore, in oncology, we're trying to say, well, let's use the antibiotics when we have to, but if we don't have to, then let's not use the antibiotics. They may be suppressing the immune response of our patients. And certainly, if we ever have to give these immune medications which cost about $250,000 a year, by the way. It's better to have them in a setting where we know the body will respond to them rather than the body will not respond to them. So as you bring up that issue of Cipro, it's one where we definitely say, if you need antibiotics, by all means, get them for the minimum amount of time that's necessary. And you say a couple of days is all you need. So that's good. And then I recommend to patients, if you've been on some antibiotics, take some probiotics, take some of the yogurts that are probiotics or other probiotic types of foods in the store. And with those probiotics, try to restore your body's microbiome to a healthier state, rather than from just a few germs that aren't really going to help your body to a wide variety of nice balanced germs that will help you. So what's in our body is really important. We have more germs in our bodies than we have cells in our bodies. So these microbiomes, whether they're in the mouth or the throat, in the stool, on the skin, these all contribute to a healthy life for us, and we don't want to see that minimized. So, I've become a proponent of having yogurts that are not
sugar.
treated, and so these are yogurts that have lots and lots of germs in them. So you want to make certain that we get the best kind of yogurts and the best kinds of foods that support our microbiomes.
Yeah, for
Good
the
question,
last 6 months, I've been taking probiotics and,
Good.
Maybe eating several of the little 90 calorie, things a day, 2 or 3 of them. But anyway, okay. Thank you so much.
Do you have another question, Chuck? Because
Yeah. Oh, yeah. The other one was
Yeah.
the terminology. That another thing, of course, I as a layman read all these things and say, how do we interpret them? The term is, and of course, topoisomerase, TOPOISOMERASE, SA2, numeral 2, I guess, in cancer, and you know what I'm talking about. Yeah.
yes, topoisomerase 2 is needed for having our cells grow. So everybody has topoisomerase 2. Some cancers have a higher than normal amount of topoisomerase 2, and we have drugs that target topoisomerase 2 and reduce it, and many of those can reduce cancers in the body. But there are lots and lots of different enzymes in the body that are targets for different chemotherapies. And so the topo2 inhibitors, as we call them, they're very useful drugs, and knowing how these will interact with hormonal therapies, radiation therapy, other immunotherapies, and other targeted therapies, to therapies that target genetic mutations in the cancers. This is all under very active study now. And as we just mentioned, prior to everybody getting on board and starting the discussion, one of the major areas that I'm seeing in prostate cancer research now is ways in which we can combine 2 or 3 or 4 of these different kinds of treatments together to see if that's better than just 1 or 2, and at what stage and for which patients is this going to be best. There's a huge discussion on AI, artificial intelligence. And what you have to realize is that we're using AI now to help to understand the interplay of the patient's genetic makeup, the tumor genetic makeup, the other diseases which a patient may have, and looking to see which of these things best predicts for the response to, say, white button mushrooms, or response to topo2 inhibitors, or response to combinations of these. There's so many variables that we have to measure in this, that using AI to help us to understand which things are most important and which things are just noise, that becomes very, very important. And obviously, more patients and more studies more patients, even if they're not on studies, that have their information that goes into medical record systems that can now be investigated by AI mechanisms, where they take huge databases from, say, different healthcare systems, whether it's Kaiser, whether it's Medicare, Medi-Cal, any of these systems, and helps to look at all these variables and say, we've identified a group that are very important in being treated with this disease. Another group, very important treatment with that disease. So this becomes very important. So if any of you are politically interested in artificial intelligence, because every single channel has artificial intelligence all over nowadays. Every newspaper has it. You can't escape it. Remember that there are going to be some very useful instances where AI helps patients, helps us to understand how to treat people. And there's going to be a lot of noise with AI just determining what kinds of ads we should be getting on our computers. You know, they know everything about us. No one will escape us. But at least we know that in the oncology community, AI is going to be very helpful. And in fact, many of the talks at our recent cancer meeting in Chicago, which took place at the beginning of this month, did have AI being used in helping to interpret the data. And many of them were very helpful in understanding which things were useful and which things weren't.
Yeah, radiologists, I understand, are really excited about this because it helps them. They don't have, when they're looking for cancer. Yeah.
Yes, the radiologist. There's so many different little aspects in all the pixels present on the digital radiologic examinations that AI is a very useful tool, and it increases the accuracy of diagnosis probably about 20 or 30%. I mean, it's not like 5 or 6 times better, but it is definitely better. And of course, it's an automated system, so presumably some radiologists will go out of work because of that. Who knows? But in the meantime, those that understand AI will work with it, and they'll do a good job with it. So, but many of you may have heard about AI, and we see different AI reports coming out in the newspapers, whether it's the LA Times, New York Times, Wall Street Journal, U.S. News and World Report, Time, looking at how AI is being used. And so I certainly don't want it to go away, but I don't want it to be used to know exactly what my next movie is that I want to watch. Some other questions you have? Sure.
Yeah, Bill Power wants to know, can a Kaiser patient participate
Yes.
in your study? What are the complexities of joining a FARA KPMG patient?
We at City of Hope, we have Kaiser patients who come over for bone marrow transplant. We can discuss with the patient if they want to participate, and discuss with Kaiser to see if they would pay for the routine tests that need to be done while the patient's on study. Any of the investigational tests, like the investigational tests of their body's immune response or the microbiome, those are all free. But the other tests that need to be done, we need to work with Kaiser and see if they will cover those types of things. It's definitely worth inquiring with us, and we can run it through our program to see if they'll pay for participation. We sure would love to have patients participate from Kaiser. And so to every extent possible where we can get blood studies done at other places like Kaiser and not have to worry about them coming to a City of Hope facility to get blood drawn, I think that's important. But some of the bloods will have to be drawn at City of Hope just because that's the way in which we get them to the immune laboratories to be able to study those and make certain that we have good results on our patients. And some of these results that we're dealing with are very sophisticated results in immune responses. It's not just antibodies, but actually types of T cells that are present in our system, T cells that become activated, whether macrophages are helping with that, whether there are suppressor cells that are being reduced by this. I mean, this is a very, very complex system that we're evaluating, and it will be helpful where everyone will know how this works and how it helps patients. So we're really excited about it. Yes.
Does somebody have a question? Dave, Bob, why don't you go ahead and I'm going to go to Dave G's question.
Okay. Doctor, thank you for speaking to us tonight. You've been mentioning this study on white button mushrooms. Is there any connection with any other type of mushrooms, in particular lion's-mane mushrooms that
Yes.
I've read about recently? What would your comments be?
We don't know if lion's mane will help or not. We know white button mushrooms in the laboratory definitely help. So my inclination would be, we know that there's going to be a lot more studies in lion's mane and other types of mushroom preparations. And we know that as those come forward, these types of phytochemicals will be able to be compared with Agaricus bisporus, which is the white button mushroom that we can all buy in the store. And lion's mane can be bought in every store and every pharmacy as well. So we know that. And so there's no shortage of mushroom preparations that you can get. Don't have any positive information about lion's mane. I don't have any negative information about lion's mane. So, the question is, well, maybe it couldn't hurt, but who knows? But we know white button mushrooms definitely can help. I mean, there's even data that white button mushrooms can reduce the onset of Alzheimer's and stuff like that, improve memory. So mushrooms, they're a good thing,
Okay.
especially the white button ones.
Yeah,
So,
thank you.
so that is good. When we've had Dave G's question. Is Dave on? Dave, you there? Dave G, I put a question in the chat. Can you participate in the mushroom study if you're taking Relugolix and or other ADTs or GnRH antagonists? And that was his first question earlier on. And we put patients into the study, can accept patients in the study if they've been off of their ADTs for at least 6 months. So we want to make certain that patients are not actively getting treatments that will control their prostate cancer if they are going to go on the study. But most of the time, patients who are getting ADTs and hormone antagonists, most of the time, those are patients who have a little higher stage Gleason's tumors, or they may have some more extensive disease. They may have already failed watchful waiting and are going on that. But once patients come off of that, they're eligible to participate in the study. So we'll see how that goes. There was a question from Bill Power. Can you recommend the best probiotics? No. Wish I could. Every company feels their probiotic is clearly the best. And so those patients who take a probiotic from one company or another company, obviously we don't want them to be taking probiotics when they're on the study. But if you're just taking probiotics generally to improve your health, I generally tend to use a yogurt that's high in probiotics rather than just getting probiotic pills per se, because I'm more assured that they have active ingredients in them. So, but I can't recommend best brand. I'd be kidding you if I said yes. There was a question from Pat Lane to everyone. Is a Gleason's 4+3 = 7? Does that qualify? No, but remember that if you have a biopsy that's 4+3 and you review that biopsy at a place that really has very expert pathologists who do prostate cancer pathology all the time, sometimes a 4+3 actually winds up being a 3+4, so that it's a better prognosis cancer. So it's always worth getting a second opinion to know if in fact you might be able to participate and see how that works. So that's a really good question. And it's one that as we look at reviews of pathology, it's remarkable how frequently the community oncologist pathologist, community pathologist, as a result, and even if several of them have talked together, when we get that biopsy in City of Hope to go over it, we see things that they missed at that other area. Also, it's useful when we have a specimen submitted, we can look at that specimen for genetics, the genome, the mutations in the tumor. So we can understand better about what types of therapy might be useful in a particular patient now or in the future. So you have a picture now, but you also have those genetic mutations can predict for what might be useful in the future. So no matter where you're being taken care of, one of my recommendations for you is, talk to your oncologist about should you have a hereditary genetic study done. They're widely available, much cheaper than they ever were before. And should your genome in your cancer be tested, that doesn't require another biopsy. Your original biopsy can be sent to the laboratory, and at the laboratory, they can check the genome. And it's a very easy process to be done. I know that everybody in my family has been having their genetic evaluation on their saliva or their blood cells to see if they're at risk for any other type of type of cancer, or even some non-oncologic diseases as well. So this can help to understand how we keep our bodies healthy and how we can take preventives and how we can get screened for things that you might not otherwise want to screen for. So I urge that you do that. Pat Lane said his Gleason's 4+3 came from Johns Hopkins. Johns Hopkins is an excellent prostate cancer resource facility. So that probably is really a 4+3. Some people who have prostate cancer biopsies done in community sites, community hospitals, they don't have the extreme qualifications that a place like Johns Hopkins or USC or UCLA or City of Hope would have available to us, or UCLA. So all of those are really good. And we have all of our pathologists down at Lennar Hospital in Irvine, at the new City of Hope facility, that are available to do second opinions as well. So it's good. Ira asked, what's your thoughts about Artera AI? Can't tell you. I'd have to research that a little bit and see exactly what that is, because I'm not familiar with Artera AI. Ira, if you're online, can you tell me a little bit more?
Yes, it's they surveyed about 2,600 patients. They looked at the biopsies. They scanned it. So what happens is they're able to basically tell whether or not someone needs ADL or not have ADL. So it's a prognosis. Not only does it evaluate the biopsy, but it uses information to determine whether ADL is needed. So they did the first stage. And I heard somebody talking about it. So now they want to they had about 60%. I think it was 60% was the what do you call it again? The information. 40%.
Positive predictive value, PPV, or
no
40%
was clinical data. 60% was the was looking at the
pathology
information from the scans. And now the next stage is they want to figure out which of that 60% is really affecting the Lupron? They don't know, so they have to do
Yes.
another study on that.
Mhm.
So that's what's going on. It's like the latest and greatest, I guess.
Mhm.
You know, that's one of the AI things. So
Well-
I don't, is it premature? You know, what
Well,
do
here
we-
are the steps in looking at these this prognostic information. The first thing you do is you get a big database, and 2,600 is a pretty good sized database. So that's a lot of patients and a lot of data points because they got the clinical information. They've also got all their pathology in there. And you get a conclusion based upon that about the sensitivity and specificity of the test and the what we call the positive predictive value. That is, if you get a positive result on the Artera AI, how many of those patients actually respond versus not. And so that's the first thing. Secondly, you need a confirmatory data set to know for sure that in patients who are not in the first group, is that in the second group, when you actually test it for the confirmatory analyses, is the same result seen. And this is very critical because sometimes what you learn from the initial data set, you try to extend that to the subsequent data set, doesn't work out. So I'm very excited that they have that
Right.
predicts for ADT androgen deprivation therapy results. Remember that there's another aspect coming down the pike also. So not only is there Lupron and stuff like that, but the combined Lupron with enzalutamide or other types of drugs which can further modify hormone responses has become very common. Thirdly, the use of ADT together with docetaxel, which can be used to increase response rates and increase survival rates, is also important. And now lots of investigators are looking at all three of those approaches together. So the question is, when you do a result like the AI that predicts for just ADT, androgen deprivation therapy, how does that predict for the response to, let's say ADT plus enzalutamide plus docetaxel? Does that hold as well? Or suddenly do we find that as long as you add enzalutamide and docetaxel to that, then sure enough, the AI may not be predictive in that circumstance. You bypassed the mechanisms of resistance to that. So it's an important contribution, but we have to look and see what the results of that study are. Sure.
By the way, I think they passed a phase 3 study,
Yes.
phase 3, and they're open for business, and they're gonna, as they have new patients, they're gonna add to the database based on
Yes.
patterns.
Yes.
So, you know, is it premature? And I don't exactly know what they're gonna be doing and who they're targeting and
Sure.
what they do. So, you know, maybe it's premature to go.
I'll look
with
into that and see what we can learn, and maybe as we go forward, Brian and Neil and Chuck can have someone from Artera come and talk
Yeah,
to the group.
we've been trying to get someone.
Successful yet or not?
Haven't seen the person yet.
Okay. Well, don't stop asking and see what's doing, and we'll see what we can find out about it. And if they can't come, then at least we can know exactly where they are now in their studies and can share that with you in the future. Okay.
Does anyone else have any questions this evening? Doctor, you're welcome to stay around. We will now go into our support group and discuss some of what's going on here.
I'm
we're
gonna beg off if you don't mind, because I have another call coming through shortly that I'd like to get ready for. Okay.
Outstanding, and I thank you so much for your time. And once again, it was a very exciting discussion, very
Well,
positive.
thanks for
gives us
such
a lot of
wonderful
hope.
questions that you all have raised and everything. You obviously are all doing your homework. Keep on doing it. and happy to come back anytime.
Thank you so much. At this point, we'll stop the recording. Yes, I want to
Good.
stop recording.